was sitting towards the last 5 minutes of Dr. Silverberg's lecture, I realized I was undergoing that first phase of the code white. I was getting more restless, anxious, I was rocking in my seat, so I realized I was about to give the first lecture of the year. So I get it, now I get it. So what I want to talk about is disaster medicine and medical simulation. Basically what I see is the stars aligning. It's preparing for the worst case scenario. I just want to thank Drs. Arquilla, Regan, Groden, and Rutsuri for just reviewing my slides for the presentation. So what I want to discuss, just want to be upfront with you, is I'm going to show you a variety of disasters through images. I want to briefly describe what to expect from disaster incidents. I'm going to ask you if you feel prepared for what the ED may encounter as a result of potential disaster, and then I'm going to pause, let you ponder, and then I'm going to talk about how we can learn from others' experiences. And then I'm going to present what I think is a great way to prepare for disasters at the EG level. And that's with medical simulation. So, disasters, they come in all shapes and sizes, all different types of forms. So California brush fires, Los Angeles earthquakes and collapsed highways, Hurricane Katrina, the disaster that brought, Superstorm Sandy, tsunamis and earthquakes in Japan. These are all different examples of natural disasters. You can see the chaos that they can lead to. Then, of course, those are natural, unintentional, they happen. Of course, we also have intentional disasters. So the attacks of 9/11, school shootings, active shooters, Columbine, Sandy Hook, San Bernardino shootings, terrorist attacks like Boston Marathon bombing, bombings in the Belgium subway, public transport in Israel, bus bombings, release of chemical agents in subways in Japan. And then, as of late, the most recent, prior to the attack in Turkey, is the Pulse attack in Orlando, Florida. So you can see, we can expect lots of different pathologies and injuries, just like what Dr. Silver was talking about. So these are relatively rare, but are becoming more common. But when they do happen, we can expect a large instantaneous casualty load with specific mechanisms of injury. So just to reiterate, explosions, blast, primary, secondary, tertiary, quaternary, and possibly even this quinary blast type injury. Gunshot wounds, ballistic injuries, shrapnel injuries, blunt penetrating trauma, crush injuries, burns, be it thermal, chemical, radiation, inhalation injuries, exacerbations of medical conditions like COPD or diabetics. And then, of course, the emotional and psychological trauma. And pretty much any combination of the above. So you can have your COPD exacerbation, diabetic that hasn't been treated, who's been trapped in a collapsed building following the Los Angeles earthquake. So this is what we can expect from these types of injuries coming to our ED. And so knowing that, do you feel prepared for when disaster strikes? Momentary pause. Continue. Are you prepared for one patient? 2 patients? 3 patients? 4. What about over 40? And that's actually important because last month in June, we had a shooting incident in Orlando. And they actually, this is us learning from each other's cases. Orlando Regional, June 11th, 2016, June 14th, Orlando Regional Medical Center. They received a lot of casualties, the largest mass shooting in American history. 2 waves of casualties within a span of about 2 to 3 hours. 44 victims brought to one hospital, and the majority of them in critical condition. So just imagine you're working in CCT, it's a busy day, and all of a sudden you just get this onslaught in about an hour and a half time span, about 44 gunshot victims coming at you. Another case, Madrid, March 11, 2004, attack on commuter trains. Instantaneous death of 177 at the site. More than 2,000 injured. More than 1,000 transferred to 15 hospitals in Madrid. In less than 3 hours, 270 patients arrived to one single hospital in Madrid. So imagine, 270 patients coming through CCT triage. So are we prepared? I brought up the Madrid case because that case was actually used as a standard for a survey of United States preparedness in 2008. So this survey was sent to about 7 large city hospitals, and definitely New York, Kings County was in there in that survey. And basically, the large conclusion was, we are not ready for the predictable surprise. Predictable because there's just so much intelligence out there that these things are constantly being planned on a daily basis. And surprise is you can't actually ever predict when it's going to happen. It's not really a matter of if, it's actually a matter of when. And so most hospitals in the survey were actually operating at 150%, 200% of their capacity. So that definitely decreases the surge capacity, that capacity that you operate beyond what you're normally supposed to be operating at. So no hospital beds, ED overcrowding, boarders, patients in the hallways, and then imagine on top of that you get 270 patients. So just a thought, how can we prepare? So enter the medical simulation. So we're doing a large disaster drill July 20th. So that's one way of preparing. That brings together a whole bunch of systems, RNs, EMS, pre-hospital care, hospital administration, ED providers, multiple departments, kind of on a large macro scale. And that's actually not what I wanted to focus on. I wanted to focus on us and the ED at triage, in the CCT, in the trauma bay, in the ER, when all of this is coming at us. So I was reviewing some papers, and I noticed this theme just started to emerge. You know, simulation, 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 virtual reality? What? I thought that was pretty cool. And of course, Dr. Zarquilla, and Dr. Sinner is like the most popular person out there. It's just his name's everywhere. Dr. Sinner, one paper. But the one paper I wanted to focus on, or the one concept I wanted to focus on that I thought was really interesting, was this idea of multiple encounter simulation for high acuity multi-patient environment training. Right, so what do? We do sim every week. We're scheduled for sim. Some of us do it every few weeks, every few months. You know, we can go after a conference, we can get some more sim experience. But what do we typically do? We see one patient as a team, we tackle that one patient, and we're good. So I think we're well prepared to tackle that one patient, that trauma patient that's coming through the CCT, that one medical resus patient, that critical COPD or asthmatic, that one pediatric PALS case. But like I said, in Orlando they saw 44 patients, critical, all at once. In Madrid they saw 270 patients all at once. So I think in that case the sum is actually greater than its parts. You're seeing a lot more patients all at once. One pediatric right next to a critical trauma, right next to a critical medical patient, right next to an OBGYN patient. It's a different kind of dynamic that I think we can simulate. So, an example of a multi-patient simulation case scenario. So up at the top, this is 3 patients. One patient's hyperkalemic, one patient's the stoic asthmatic, so 2 medical cases, and then the third patient is a penetrating stab into the neck. And on the y-axis, you can see it's all time. So this is an example of just one case, one complex case, greater than just one patient. So it's a team managing 3 patients all at once, 2 medical patients, 1 trauma patient. And it allows room for error, too, because you can imagine more patients, more complexity, more room for error, but you can recover from that error as well. So this is just one example, but you can imagine that given that you're working with now not just one patient simulation, but at least 2, you can make this library basically infinite. You can change the hyperkalemic patient to a peds patient, right next to patient number 2, an OBGYN patient, right next to patient number 3, a trauma patient, adult, peds, or medical. And you can really make these cases really complex and really simulate what could potentially be encountered in a disaster incident. And you could also model these after disasters that we're most likely to encounter. So for example, less likely to encounter the 7.6, 8.1 earthquakes that they would encounter in Los Angeles. So maybe we don't have to focus specifically on crush injuries and get the dialysis units set up. But we live in New York City, and New York City is no stranger to terrorism. We have public transport, we have a lot of landmarks. These are always targets, and so it's always that matter of when, not if. Question for you. Is this also like a regular CCT shift? So if you think about it, sometimes CCT shifts, so I heard last week, I actually wanted to use a picture of the whiteboard from the CCT shift last week. And I saw there was 5 or 6 gunshot wounds, one person who had an epidural secondary to a pickle jar to the head. And clearly, very quickly, things can get overwhelming. So is CCT on a busy night enough? And I think it's fantastic for training purposes, but I think the one element that simulation asks adds is that element of debriefing afterwards. So it's a more formal, simulated environment that also adds that aspect of debriefing. Triage. Triage is a critical component of both in the field disaster management as well as that ED triage that happens when patients start to arrive from a disaster incident to the hospital. And so this aspect also can be added to simulation cases. So you can imagine a simulated cases multi-patient scenario that starts out with triage and then just flows right into actually managing those cases that you're going to prioritize up front. So virtual reality, I thought this was so cool. Virtual reality used to perform medicine, both trauma and medical. So this is just one study that was looking at out of Michigan where they created this whole software environment, a virtual world, where you can do triage just by wearing a headset, virtual reality headset. So you get this guy wearing a virtual reality headset and he's doing something with his hands. So what he actually sees in that virtual reality headset is this patient on the screen. Really, that patient really isn't there, but he's actually palpating a pulse. You can imagine the options of this are actually pretty endless. You can create entire virtual worlds. And when I was reviewing this stuff, it's really cool. So you know how they have the AHA, the ACLS, that little sim thing that they have on the computer? So that's what we did for ACLS algorithm, rather than the SVT, the cardiac arrest. They have those for trauma, for chemical warfare, for biological warfare. So it's actually really cool. Now, having said all of that, I think this is a great way to prepare for the disaster that's going to come to us, being the ED provider up front. So what can we do? We're going to get virtual reality headsets? Probably not. Are we going to get 5 more mannequins so that we can do this multi-patient sim? Probably not. Can we add multi-patient simulation cases? I think so. With mannequins, maybe, maybe not. Each mannequin is like $30,000. If you multiply that by 5, that's a lot of money. These virtual reality headsets, they're going on several $100s, plus the kind of complicated software that we have to learn. But I think that adding multi-patient simulation is something that we can do with both moulage actors, with or without 2 mannequins at once, for example, peds mannequin and adult mannequin. Mixing adult reactions into a single case. Making simulation interdisciplinary, maybe inviting surgery, OB, RNs, peds. Mixing trauma with medical patient resus. So what would a disaster sim case potentially look like? Triage, actually doing the simulation of triage up front in the case, followed by a multi-patient sim on an infinite amount of cases that you can library, followed by a debrief. So, in summary, disasters aren't going anywhere. It's a matter of when, not if. We need to be leaders in disaster preparedness. And I think that medical simulation is the best way to prepare for a potential worst case scenario. Thank you for your attention. These are my references.